Okay. Lots of words. Okay, so this is the junction of the wrist is at the junction of the forearm and the hand. Move the hand takes place at the wrist joint and articulation between the expanded lower end of the radius and the articular disc of the distal radio ulnar joint proximally in the first row of the carpal bones. Okay, so biggest takeaway from these first two sentences, when it comes to articulation of the wrist, so I've spoken about this before, but I'm going to repeat it. When it comes to actual articulation, so movements of the bones. So your humerus articulates with your ulna. Your ulna articulates with the radius, both proximally and distally. And then it's the distal radius that articulates with the carpal bones. So when you're bending your wrist to flex it and extend it, that is the movement of those carpal bones as they articulate with the radius, not with the ulna. At the distal ulna, you'll see that like there's some ligamentous attachment between the distal ulna and the carpal bones, but that's not what we really consider the articulation at the wrist. The articulation is happening between the carpal bones and the distal radius. The hand consists of dorsal and palmar surfaces. So your dorsal surface is your posterior versus your palmar surface is your anterior. The functional importance of the hand can be gauged from the fact that injuries to the hand account for more than 1/3 of all industrial accidents. Okay, much of the efficiency of the hand depends on the thumb. And we're going to talk a lot about all of these things happening. Okay, so I'm just going to skip that slide full of words and we'll come back to it later. So these are the bones of your hand. You have your carpal bones, which are your wrist bones down here. You have your metacarpals, and then you have your phalanges. When we talk about the bones of the hand and we count starting at the thumb and then going towards the little finger. So this will be your first metacarpal, second, third, fourth, and then fifth. For your phalanges, you want to note that digits 2 through 5 have 3 phalanges. So you have a proximal, a middle, and a distal, versus your thumb just has the 2. So it has a proximal, a distal, but it does have its own metacarpal. And then we'll talk about the individual carpal bones, I'm sure, coming up. And here they are. Okay, so there are 8 carpal bones. I learned them sort of in order. So from lateral to medial and then lateral to medial again. So scaphoid is this guy right here. And then here's your lunate. Then it's triquetrum and then pisiform, followed by trapezium, trapezoid, capitate, and hamate. So some important things about these bones. When you're born, they're not all ossified, so they don't have all of their calcium and phosphate when you're born. That happens as you grow. And they've actually, like, there's a chart here showing you the rough, like the estimated times of when these bones get their calcium and phosphate, when they ossify in kids. So important things to note is the ones that ossify the earliest and the one that ossifies the latest. So your capitate and your hamate are the ones that ossify first, as opposed to your pisiform ossifies last. And this is a way that you can use to age a child. So you can just look at an x-ray and see, oh, okay, so these bones have ossified. So this kid is around like 3 months old, guesstimation, versus all of these bones are ossified. So you know if it's a girl, the child is at least 9 years old, versus if it's a boy, the child is at least 12 years old. So you're going to want to memorize all the names of these bones, and you're going to want to memorize in general when the bones ossify, because they can ask you a question where if it's a 6-month-old about how many bones in their wrist do you think will be ossified, something like that. Other things that are shown here that are kind of important. So the anatomical snuff box, if there isn't a better picture in this slide deck, I'll have one for y'all. But the anatomical snuff box is important because it's in this general area. It's made by tendons from your posterior forearm. The radial artery passes through it, so it is a way for you to actually get a radial pulse. And also the scaphoid bone forms the floor of your anatomical snuff box. Speaking of the scaphoid bone, it's the most common carpal bone that gets fractured versus your lunate is the most common carpal bone that gets dislocated. Okay, and then this is showing you different ligaments in the area and how they're all trying to like hold the bones together. I'm not sure what specifically she said is important about this, so I'm going to keep going because there's a lot more. Just making the point that there's metacarpal, phalangeal, and interphalangeal ligaments helping to hold the bones together. Okay, so this is your palm, superficial dissection. So if you take up the skin and the subcutaneous fat, you can see here this palmar aponeurosis. The palmar aponeurosis is an outgrowth from your palmaris longus tendon. It extends out and then it thickens. And so you have, this is your palmar aponeurosis. You can also see here how you have your hypothenar muscles for your little finger versus your thenar muscles for your thumb. When you see thenar, know that that's representing a group of 3 muscles, or OAF muscles. So opponens, abductor, and flexor brevis. So your little finger has those 3 muscles for the hypothenar eminence, versus your thumb has those 3 muscles for the thenar eminence. Okay. And then she didn't really put any words here to say what's important. So I guess I'll just talk about the fact that you can see here is your ulnar nerve as well as your ulnar artery as they're passing through the ulnar canal, also known as Gunyon's canal, and the hook of hammates over here. So if you break your hook of hammate because it's close to where your ulnar nerve and your ulnar artery are passing, you can actually damage the nerve or the artery when you have a hammate fracture. Okay. So going a little deeper, we've now peeled away our palmar aponeurosis. And you can see here tendons going out to the digits, as well as bursa that are surrounding these tendons. So I'm trying to think what would be important. What would she care about most? All right, so the arrangement here of the bursa is the most common arrangement of them. So you have this one big bursa for these 4 tendons, plus here's one bursa here for this tendon. So this is a way that if, say, you get cut or your little finger, or you get bitten by an animal, you can actually have the infection spread down your finger via this bursa. And it's called the ulnar bursa. Other things are important, so you can see more clearly, here's that ulnar nerve as well as the ulnar artery, and it's giving branches to, so it's giving blood flow to your superficial palmar arch here, because remember, we're more superficial at this point. You can also see your median nerve coming through, and then giving the branch for innervation of your thenar eminence over here. So when it comes to innervation of muscles in the hand, your ulnar nerve innervates most of the muscles of the hand. Your median nerve only innervates, the mnemonic that we use is 1/2 loaf. So 1/2 standing for the first and second lumbricals, and then the OAF standing for your thenar eminence over here. Okay, so in this picture from Netter, they've taken away the palmar aponeurosis, and you can see even better the bursa surrounding these tendons and your hypothenar as well as your thenar eminence, your ulnar nerve, and your median nerve coming through. So as I said before, this is a common variation of the bursa arrangement of the tendons. This is the most common form, like the usual arrangement. However, this is a variation, so this could be a way that if it were in a question, a person could get like bitten on their little finger, and the infection could, in theory, spread to their thumb. It would be from this bursa. So you're going to want to know. So just FYI, just remember that this is a common variation. However, this is how it's usually arranged. Okay, this is zooming in on the bursa around the tendons. So remember or recall back from when we were learning our anterior forearm muscles, how your flexor digitorum superficialis tendon versus your flexor digitorum profundus tendon insert. So your flexor digitorum superficialis is the tendon that actually splits versus profundus is the one that goes all the way out to the tips. So superficialis is going to insert here and over on the other side versus profundus is going to insert over here. So profundus is the one that's bending at the tips. Okay, so your lumbrical muscles. You can see here how you have 1, 2, 3, 4 lumbricals. Recall that they have different innervations. The first and second lumbrical are innervated by your median nerve, but the third and fourth lumbrical are innervated by your ulnar nerve. Notice how also your first and second lumbrical only have 1 muscle belly versus your third and fourth lumbricals have 2 muscle bellies. So you can actually call them unipinnate versus bipinnate. And this is just the bursa again, so I'm going to keep going. Okay, so our carpal tunnel. It's important that you actually memorize the contents of your carpal tunnel. So we'll start with the roof of your carpal tunnel is here. That's your flexor retinaculum. The floor of your carpal tunnel is the actual carpal bones. The contents of your carpal tunnel are seen here. You have 9 tendons and 1 nerve. That 1 nerve is your median nerve, which you can see here. The 9 tendons are, first, the tendon from your flexor pollicis longus muscle, and then the tendons from your flexor digitorum superficialis and your flexor digitorum profundus. You're going to want to memorize the arrangement of these tendons as they're traveling through the carpal tunnel. So your flexor digitorum profundus muscle, its tendons travel flat through the carpal tunnel. So just 2, 3, 4, 5 going lateral to medial. Versus the tendons of your flexor digitorum superficialis are actually stacked. So tendons 3 and 4 are stacked on top of tendons 2 and 5. So this is the tendon that's going to digit 3. This is the tendon that's going to digit 4. This is the tendon that's going to digit 2. And this is the tendon that's going to digit 5. So you want to memorize the arrangement of these tendons. So you got to know what's the roof, what's the floor, what 9 tendons travel through, what 1 nerve travels through, and what is the arrangement of the tendons in your carpal tunnel.
What did you say the roof was again?
The flexor retinaculum.
Okay, thank you.
So you can see that right here.
Can you go over the tendons one more time?
Sure.
I'm sorry.
Not a problem. So there are 9 tendons that travel through your carpal tunnel. The first tendon I'm going to talk about is your flexor pollicis longus tendon. You can see it's the most lateral tendon, and it's going out to your thumb. So whenever you see pollicis, think thumb. So flexor pollicis longus tendon. The other 8 tendons are from 2 muscles, your flexor digitorum superficialis, as well as your flexor digitorum profundus. Notice how your flexor digitorum profundus tendons, all 4 of them travel flat in the carpal tunnel. So this is the tendon to digit 2, tendon to digit 3, tendon to digit 4, and tendon to digit 5. So flexor digitorum profundus tendons travel flat through the carpal tunnel. Contrast that with the tendons of flexor digitorum superficialis. You can see that they're stacked 2 on top of the other 2. So the tendons to digits 3 and 4 are stacked on top of the tendons to digits 2 and 5. They have the arrangement over here to help you remember the way the tendons are stacked. Or if you need a mnemonic, the way I remembered it was 34 over 25. So 3 and 4 over 2 and 5. So this is flexor digitorum superficialis tendons.
I appreciate that because there's the question where there was a boy who had a laceration and he severed the carpal tunnel, and they asked me what was the most superficial tendons that were severed, and it's going to be that the 3 and 4 first. Yeah.
Correct.
I have a question for you.
Go ahead.
You said there's 9, right? So is it like 4 for the superficialis, 4 for the profundus, and just 1 for the flexor pollicis longus? Does that make it the 9?
Correct.
Okay, thank you.
Sure.
Can you repeat what the base was again, please?
The floor of the carpal tunnel is your carpal bones.
Thank you.
So I guess looking at this picture, the flexor carpi radialis tendon, that's not inside of the tunnel then.
Correct. So when you're looking at your flexor retinaculum, it's actually below here. So this flexor carpi radialis tendon, not in the carpal tunnel.
Gotcha, makes sense, thanks.
Sure. Okay, I'm gonna keep going. All right, so now flexor tendons, arteries, and nerves of the wrist. Okay, so you can see again, here's your ulnar nerve that's traveling along with the ulnar artery. Here's your median nerve as it's going in to the carpal tunnel, and then it's going off to innervate its 1/2 loaf. And then here's your radial artery as it's giving blood supply to the arches in the hand. Yeah, this is just another really good picture. So we're gonna keep going. Bursa spaces and tendon sheaths of the hand. So when they do a cut like this, because you can see this later on in other areas, they're trying to give you an idea of what the 3-dimensional mapping of the hand is like. So again, here's your hypoxanar eminence. Remember that's those 3 oaf muscles for your little finger. When you see the names for these, they'll have digiti minimi, which literally translates to little finger in the name. Versus, so they're not little, but I think these are your Thenar as well. They're also, you can see here, your Palmar Aponeurosis, as well as your Dorsal Interosseus. The way that we learn these when I was learning anatomy, excuse me, we learn them as our pads and our dabs because our Palmar Interosseus, excuse me, adduct the fingers of the hand versus our dorsal interosseus, our dabs, abduct the fingers of the hand. So you can see here, these are also like, I believe these are your lumbricals that it has it labeled. Yeah, lumbrical muscle and its fascial sheath. So you can see here the lumbricals as they are originate, and then further up, or more distally, I should say, they would insert. More pictures of bursa. So this is just showing you the tendons as, so this is another view of the carpal tunnel, but with the tendons wrapped in their bursa. So you can see how here's the 2, the 4, and then the 1. And then they just continue on But when they come out of the carpal tunnel, they flatten out again because they have to go to their individual digits. Okay, so again, talking about our palmar interossei versus our dorsal interossei. Okay, so one thing that helped me understand my pads and my dabs was the thing that, if you look at the Dr. Preddy video, he has 2 videos on YouTube all about the upper limb, and he does this demonstration, so I'm just gonna kind of walk you through it right now. If you take your hand and you open up your fingers and then close your fingers, open up your fingers and then close your fingers. But if you stare at your middle finger while you're doing this, you'll notice that your middle finger doesn't really move all that much. Well, that's because the middle finger is the actual center of the hand. So when you move away from the middle finger, like they're showing in these arrows, you're abducting the fingers. Versus if you move towards the middle finger, you are adducting the fingers. So this helps us understand why we have the arrangements of pads and dabs. If you ever move the middle finger, it is automatically abducting because the finger at rest is adducted. So your middle finger here has 2 dabs, 2 dorsal interossei, because moving it in either direction is considered abduction. Versus here, your palmar interossei, there's no palmar interosseus for the middle finger because at rest, it is adducted. So we actually have our 3 palmar interossei here versus our 4 dorsal interossei, because you can see here, here's the 2 on the middle finger, 1 on the index, 1 on the ring, and then our digiti minimi has its own abductor that can pull it over, so it doesn't actually need its own dorsal interosseous muscle. And just to reiterate, your palmar interossei can be called unipinnate, your dorsal interossei can be called bipinnate, because uni means 1, so 1 muscle belly, bi means 2, so 2 muscle bellies for each muscle.
I have a question about this slide if you're about to move forward.
Oh, no, go ahead.
Okay. During class, we talked about just like what you said, like on the dorsal side, you have the adductor digiti minimi muscle and you have the abductor pollicis brevis muscle. So they don't necessarily, I guess they don't need the interosseous because they have their own muscles. Am I saying that correct?
Correct.
But then on the palmar side, we talked about the adductor, yeah, so the adductor pollicis brevis muscle not needing the interosseous because it has that muscle. But we didn't talk about the pinky, like on the dorsal side. Does the pinky not have it on the palmar side?
So it does have it because you can see it here.
Right.
Your third pad for adduction of the little finger.
2, 3, 4, 5. Okay.
Yeah, so your palmar interosseous muscles, 1 is on your index finger, 1 is on your ring finger, and 1 is on your pinky finger. You don't need 1 on your, oh, go ahead.
Oh, no, you go first, sorry.
Sure, you don't need 1 on your middle finger because remember at rest, it's adducted. And then the thumb has its own abductor. It has abductor pollicis, which has like 2 muscle bellies and it's its own muscle and thing.
But the pinky has an interosseous on the palmar side.
Correct.
But on the dorsal side, it has its adductor digiti minimi muscle.
Correct. Because remember, that's
it does.
Oh, go ahead.
I was just gonna say, and it doesn't have it on the palmar side, or at least it doesn't have it in this picture.
True. Because you can see here, they're pretty much lumping in the abductor digiti minimi with your dorsal interosseous muscles. So the dorsal interosseous muscles are here, 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 and here, these 4. And their whole point, their action is to abduct. Well, the action of the abductor digiti minimi muscle is to abduct the little finger. So it doesn't need a dorsal interosseous muscle to do it because it has abductor digiti minimi.
Okay.
Just like your
Thank
your thumb doesn't need it either because it has abductor pollicis brevis.
Okay.
Okay,
Thank you.
sure, no problem. All right. More about intrinsic muscles of the hand. Oh, so because I mentioned it before, here's your adductor pollicis muscle, by the way. I was talking about that it's its own thing for adding. So for a deduction of the thumb. And I guess the point for her showing this picture is just so you can get another idea of, so here's your thenar eminence, here's your hypothenar eminence, abductor pollicis muscle, and then you can see just some of the muscles as they're layered in together. I believe this is your, yeah, these are your lumbricals here that they've peeled away. Okay. And then this is just like a graphic representation of where the muscles are on the hand. Okay, so arteries and nerves. When it comes to the arteries of the hand, it can be a bit confusing. So I'm going to try and help y'all with this. So the first thing that you need to know about the arteries of the hand is they represent an anastomosis between your ulnar artery and your radial artery. So both your ulnar artery and your radial artery are giving blood supply to your superficial palmar arch, which you can see here, as well as your deep palmar arch, which I'm sure you're going to be able to see soon because this is just like the superficial layer of blood. But this, starting off, is your superficial palmar arch. So you can see ulnar artery coming, and then here's a branch going into the superficial arch, and then here is the branch from radial artery going into the superficial arch. So this is your superficial palmar arch. And then your superficial palmar arch, it gives off branches to digits 2, 3, 4, and 5. Now they've taken away muscle and they've gone a little bit deeper, and you can see here is your deep palmar arch. And if you keep traveling, you can see, oh, hey, there's radial artery also giving blood supply to the deep palmar arch. Other important blood vessels that I want to point out in this picture. So if you continue on with radial artery, you can see here that you have this artery right here. This artery is your princeps pollicis artery. So literally translating into principal thumb artery. So the thumb gets its blood supply from radial artery. The other blood vessel I want to make note of right here is your Radialis Indicus artery. So the artery to the index finger from that branches off of radial artery, your Radialis Indicus. This is giving blood supply to the lateral side of your index finger. So princeps pollicis, Radialis Indicus, both of them are branches from your radial artery. Okay. So it's not as easy to see in this picture, but a thing that I think is important and should make note of, you can see how there are branches coming off of your deep palmar arch, as well as your superficial palmar arch. Well, those branches come together as the common palmar digital arteries. So this is where the superficial and the deep arches anastomose. And then it's only for a moment here at the distal portion of your metacarpals, because then they split to give blood supply to either side of your digits. So you can see that here. And when they do that, these are your your palmar digital arteries. So
You said the palmar digital arteries is when the deep and superficial arteries anastomose.
yep, you can
Okay.
see that. You can see here. So this is your branch coming off of the superficial arch. This is your branch coming off of the deep arch, and there they join together.
Perfect. Thank you.
Sure. And then it splits off almost immediately to become your palmar digital arteries. Okay. And okay, so this is the netter picture that is like the best picture when it comes to the anatomical snuff box. So your anatomical snuff box, and you can pretty much feel this in your hand. If you take your hand and reach your thumb all the way back, if you feel at the base of your thumb, there's going to be this area that you can sort of stick your finger into. That's the anatomical snuff box. You need to know the tendons that are like the borders of this area. So you can see, does it have it labeled here? Yep. Here's your adductor pollicis longus. And then here's your extensor pollicis brevis. And then your extensor pollicis longus. So all three of these tendons are considered the boundaries of your anatomical snuff box. They've labeled here for you, there's the scaphoid bone, then your trapezium bone, and then the first metacarpal, because remember the first metacarpal is a part of the thumb. There's your radial artery passing through the anatomical snuff box. So Dr. Austin has labeled contents of the snuff box that she wants you to remember. So you've got your radial nerve, specifically the dorsal digital branch, which, let me see if I can find it. I think this might be it. And then you've got your cephalic vein branches, which have been cut away. Then your radial artery, your scaphoid bone, your trapezium, and then the base of your first metacarpal. So as soon as she listed them, it would be a good idea to know them. Okay. So looking at the dorsal side of the hand for superficial dissection, you can see after they've taken away the skin and the subcutaneous fat, you have a network of dorsal venous branches on the dorsal side of your hand. And remember, our venous blood is traveling from distal to proximal. Oh, okay. So I have a hand PowerPoint that I use for review. So I'm going to go through some of that in the next like 20 minutes while we're still here to hopefully clear up any questions and then bring up some clinical correlations of stuff that I know I needed to learn when I was taking anatomy. So this PowerPoint should be available in your class drive. For reference, the Dr. Preddy videos that I suggested, these are the two links on YouTube. If you literally go into YouTube and type out Dr. Preddy anatomy, it should pop up anyway. But he goes through the muscles of the upper limb, including the hand. And I think later on, he has a different video where he goes through the brachial plexus to walk you through that too. But he explains like all the different muscles and their innervations, so he's super helpful. Excuse me. Anatomy Zone is another good resource if you are a person who studies videos. They've got so many videos on YouTube, but these are some of the ones that were helpful to me. So just going through the nerves as well as the arteries of the hand and wrist. And as always, Gray's, Moore, and Netter Atlas are super helpful. Okay. So I'm going to skip over some of this because we've already talked about it. Okay, I think we've already talked about this too. Okay, so just to give you an example of x-rays, this is an x-ray of a scaphoid fracture. You can see that here. as well as here, as well as here. It's important to remember that your scaphoid bone is the most commonly fractured carpal bone. For hamate, I mentioned this before, but just to reiterate, ulnar nerve and artery passed really close to the hook of hamate. So if you fracture the hook of hamate, you can damage them. And then again, Gunyon's canal, also known as the ulnar canal, with the ulnar nerve and artery passing through, which is another place we can get a compression injury. And some x-rays of hamate fractures. So she didn't mention Boxer's fracture, but I'm going to mention Boxer's fracture. It's a common clinical correlation when it comes to the hand. So the irony is that they call it Boxer's fracture, but most often the people who get this injury are unskilled people who throw a punch. So because they are slightly abducted when they throw the punch, the force of the punch ends up on their fourth or fifth metacarpal, and they'll end up breaking off the distal head of the bone. So it'll look like this on an x-ray. Now, if they talk about it being a professional boxer that has a break in their hand, then you would start thinking about the first or second metacarpal, because they're going to have proper form and have like a straight fist when they punch. It is unprofessional people who are just like in a bar fight or something, or they've punched a wall. Those are the folks that are going to have the breaks on the fourth or fifth metacarpal. We already talked about the carpal tunnel. And just remember, 9 tendons, 1 nerve. You got to know this setup. Okay. So, innervation for the hand. When it comes to cutaneous innervation, this is a good way for them to get you when they're asking questions. So you have to memorize the cutaneous innervation of the hand. Some of the tricks that I learned to help me with this. So the first thing that I learned was that the fingertips are never the radial nerve. It's always going to be median or ulnar nerve for the fingertips themselves. So notice how median is going to be the tip of the thumb, first and second, index finger and middle finger, and then 1/2 of the ring finger. Versus ulnar is going to be the other half of the ring finger and then the little finger. So the split of the ring finger on the palm is ulnar and median. So median, ulnar. Versus the split of the ring finger on the dorsal side. Well, for the tips, it's ulnar versus median. But then if you look over here, radial nerve splits at the middle finger with ulnar nerve. So that can be a bit confusing. So just remember, for the fingertips, never radial. The split is median, ulnar for the palmar side on the ring finger. But then coming proximally on the dorsal side, it's radial nerve and then ulnar nerve. So part of the cutaneous innervation of the thumb is radial nerve, specifically the superficial branch. So make sure either you can remember this in words or remember these pictures. We definitely want to know the cutaneous innervation of the hand. And then just to, as a callback to earlier, for innervation of muscles, remember your musculocutaneous nerve that's innervating the anterior arm, like the proximal anterior arm. So its terminal branch is your lateral antebrachial cutaneous nerve, which comes all the way down to here, all the way down to the wrist. So if you damage your musculocutaneous nerve proximal to here, you'll lose cutaneous innervation all the way down on this lateral side of your forearm. Okay, so I mentioned it before, I'll go over it again. Your thenar versus your hypothenar muscles. So they both share these OAF muscles, the opponens, the abductor, and the flexor brevis. You can see here your flexor pollicis brevis, your opponens pollicis, and your abductor pollicis brevis for the thumb versus your abductor digi-minimi, your flexor digi-minimi brevis, and your opponent's digi-minimi. So your thenar eminence versus your hypothenar eminence. Hypothenar, little finger, thenar, thumb. All right, and that was the same thing with the bursa. Okay, so your adductor pollicis muscle that I was talking about before, you can see here how it has two muscle bellies. It originates on your third metacarpal as well as your capitate bone, and then it inserts here at your PIP for your thumb. So remember, for action, you bring the insertion towards the origin. So adductor pollicis, adding the thumb back into the hand. And since this is not part of the 1/2 loaf, we know that this muscle is innervated by ulnar nerve, specifically the deep branch. Also in this picture, you can see, and they just sort of added it, but I'll make note of it. Here's your radial artery that comes, and you can see that's split for your princeps pollicis artery versus your radialis indicus artery. Okay, and then again, talking about symmetry of the hand, abduction versus adduction, all about the middle finger. Okay, and your pads and your dabs. Okay, we talked about this. And then this is like just talking about the actions of the lumbricals for full extension of the fingers. Okay, so innervation of the intrinsic muscles of the hand. So innervation for the muscles of the hand is mostly ulnar except for the 1/2 loaf, the first and second lumbricals, as well as the 3 muscles of your thenar eminence. So this is a mnemonic that me and my friends use to try and remember all of the different ways where if you damage a nerve, what will the patient have as a sign or symptom. So the mnemonic we used is Dr. Kumbasik. So the DR of doctor representing wrist drop, which you get from radial nerve damage. The CU representing claw hand, which you get from ulnar nerve damage. The MBA representing either ape hand or Benedictine attitude, which you get from median nerve damage. The SE representing superior trunk damage causing Herb Duchenne palsy. And then the IK representing inferior trunk damage, which will give you Klumpke. So this is just a helpful mnemonic that me and my classmates used when trying to remember all of this. Okay, and speaking of hand deformities, here's your claw hand, your wrist drop, and your hand of benediction. So for hand of benediction, or it depends on if the hand of benediction is as an action when you have the patient try to make a fist versus the hand at rest. Because if you ask the patient to try and make a fist, you can notice here how the little finger and the ring finger are both still moving, but these 3 fingers are not. That's because you have median nerve damage. Versus if your patient came in and they said that they noticed slow contraction of the fingers towards the hand, that could be Dupuytren's contracture. Versus you can actually have, ulnar nerve damage cause this, but it's more of a passive thing. But let me not get too much into that. So just realize that you need to understand what is happening for your patient to get a hand deformity like this. Are you asking them to make a fist and it looks like this? Versus have they said that it has been slowly and slowly like turning into this? So yeah, just median nerve injury versus Dupuytren's contracture. Speaking of Dupuytren's contracture, you can see how it can start off where there's just a nodule and some pitting, but then the fibrosis happens and you see your fingers, like your fourth and fifth finger being pulled towards the palm, and then it gets worse and worse such that you now have at rest. And it looks like hand of benediction, but it's not. It's Dupuytren's contracture. Versus if you ask your patient to make a fist and then when they make the fist, it turns into this particular arrangement of fingers, then that is median nerve damage. Okay. All right, and then I just had some more blood pictures because I pulled these from Grey's Anatomy because it's for some reason like the Grey's Anatomy pictures, I guess because they're just clearer because they take away more stuff, but you can see your superficial versus your deep palmar arch, the branches coming off of them, where they anastomose and then split out to give blood supply to the fingers, as well as your princeps pollicis and your radialis indicus. And then this is on the dorsal side of the hand for blood supply. So I think I wanted to make note of is that you can see your anterior interosseus and your posterior interosseous arteries. We know that they branched off more proximally, but they do come back together and give blood supply to the dorsal carpal arch. So this is on like the dorsal side of the hand and giving blood supply to the dorsal side of your carpal bones. And still your radial artery and your ulnar artery are giving branches to here too. But since Dr. Austin didn't like mention them, I'm not gonna like belabor the point, but I just wanted y'all to see that like the anterior and posterior interosseous arteries didn't just disappear. Okay. And then for clinical correlations, so some of these I pulled straight out of Moore. So a mallet finger, also known as a baseball finger, happens when you have sudden severe tension on a long extensor tendon, and it can end up avulsing. So basically, the example that they like to give is a person is playing baseball and they slide into the base, but then they mistakenly have their hand hit the base, and so it can cause a rupture of the tendon. And so it ends up looking like this, like a mallet. So that's like mallet finger or baseball finger. The swan neck deformity is what you'll see in patients often who have rheumatoid arthritis, RA, or they can have a genetic disease that has to do with connective tissues. So Ehlers-Danlos, which that is like further on, we're in microbiology. But you'll see flexion of your DIP here, and then hyperextension of your PIP. So notice how this is flexed, but this is hyperextended. That's your swan neck deformity, which you can see, unfortunately, in this patient. Anterior interosseous syndrome is something that comes up in relationship to a branch off of the median nerve. So the anterior interosseous nerve, the way that you test to see if this particular nerve is still working properly is you ask your patient to form the OK symbol. If they're able to put the tip of their finger to the tip of their thumb and close off that O, you know that the anterior interosseous nerve is fine. Versus if they flatten out that finger, they give you the pinch, that's abnormal. That can tell you that the anterior interosseous nerve has been damaged. So anterior interosseous is a branch off of median. So remember, we need flexion at that DIP in order to work. So if you don't have that flexion, that tells you that it's like some sort of damage happening to that nerve. And if they want to be specific, it's the anterior interosseous nerve. But this was one of the things that was pulled out of one of the more blue boxes. Okay. We already talked about Dupuytren's contracture. And then these are just other things that I pulled out of Gray's Anatomy. And I think that was it. Okay. So like I said, this PowerPoint will be available for y'all. It should be available for y'all in your class drive. I'm going to stop sharing now and ask, are there any questions? Somebody asked, will you rename the boundaries? The boundaries of what?
That was when we were on the first PowerPoint, but it's fine. I'll go back and watch the recording.
Okay. Are there any final questions as we're wrapping up?
Are these recordings on the in the class drive?
They should be after every session. I send a message to your class rep and get them to hopefully download the video for y'all and upload it to your class drive. So they should be there.
Thank you.
Sure.
I have a question. How do you best prepare for Dr. Austin's quiz or test?
If she gives you any practice questions, do all of them. Hold on. So since we're not doing actual material, I'll stop recording now and like keep answering questions.